Dear friends, today my presentation is on laser angioplasty for percutaneous coronary intervention. We've just acquired the laser machine and done a couple of cases. So this is our initial experience with the use of excimer laser for percutaneous coronary intervention. So this is the laser machine, and it's a heavy machine. It's a 650 pounds machine. So, and it needs 5 minutes of warm-up period. So before we actually think of a laser, it is important that the machine has to be acquired, and this is a very heavy machine, and it will need a warm-up of at least 5 minutes inside the cath lab. And this is the catheter, the laser catheter. These are the fiber optic the fibers, and this is the wire. So this is the laser catheter. So this is 0.9 mm rapid exchange catheter. This is hooked onto the laser machine, and this is the distal end of the catheter. The coronary catheter is 0.9 mm, and it has 65 fibers, and each fiber is 61 micron in thickness. So that is great engineering with this particular laser coronary catheter. So we've just cut the tip to show this laser catheter wires. These are the optic fibers. Fantastic engineering. You can see the optic fibers. The ultraviolet light is a 308 nanometer ultraviolet, and the laser mechanism of action is that it works through the light pulse, sonic wave, and through the vapor bubble. Now, light pulses, when light is transmitted from the machine into the catheter tip and up to the plaque, and it helps in ablating the atherosclerotic plaque. And the sonic wave will actually impact the calcified hard material, and it also changes the compliance of the vessel, and the vapor bubble will actually debulk the plaque, and therefore there will be an increase in the gain in the lumen of the coronary artery. So the light pulse is absorbed by the plaque, and it breaks the molecular bonds. It gives a lot of energy, but it's not a hot laser. It only affects what is directly in front of the light, and because it is not a hot laser, but gives a lot of energy, still it does not cause dissection or perforation. So all the cases that we have done, we never had a perforation or a dissection. There is no large material, hence it does not embolize. The sonic wave is transmitted, which impacts the hard calcified atherosclerotic material. It affects the material intraluminally and medially, and it is safe on the soft tissue and causes a crack on the calcified plaque, and it also changes the compliance of the vessel, making the vessel more softer. The vapor bubble expands and collapses, and it debulks the plaque. We use an energy of 30 fluents or 60 fluents. It's a cool, safe laser. It vaporizes the material with a low pressure, and it does not send the bubble downstream. Hence, there is a low embolization risk. Now, for the flushing, either you use a saline or a contrast, but we normally use a saline for an uncrossable lesion or an undilatable lesion in the coronary vessel. And you see that a lot of energy is generated by this particular laser. And if you look at the contrast, it creates bubbles. And this is a very high energy bubble when contrast is used. And we use contrast only when there is instant restenosis. So if you look at laser versus orbital or rotational atherectomy, there is no change of the wire. So it's the same 0.014 wire which is used. And over that only you can put a laser catheter. Very easy to use the laser catheter. And sometimes it works like a micro catheter, so it's not that bulky. But even if it does not cross a very critical stenosis, at least it modifies the plaque so that you can subsequently dilate the lesion with the balloon and deploy a stent. So these are the 5 essays which have to be remembered in laser, and these were published by my friend Moroni Gred. The first is the selection of the patient. The second is the size of the catheter. The third is the settings on the machine, both for the energy and the fluency. And the flush, a saline or a contrast, but preferably a saline flush. And the slow advancement of the laser catheter, less than 1 millimeter per second, is important. So lesion preparation is important, and in many cases, you will have a large thrombus or a severe calcification. If there is a large thrombus load, we do a thrombectomy with the export catheter. If there is a severe calcification, then you either use a rotablator or an orbital atherectomy. But in the last 2 cases, when we were having large thrombus and calcification, laser has worked very well. So laser is a one device which will work in the presence of both calcification and a thrombus, especially in the right coronary artery. The 3 main indication of using a coronary laser is when the balloon uncrossable lesion, balloon undilatable when there is a waste on the balloon, and there is a large thrombus burden. So if you look at this particular registry, the LAVA registry, which was published in 2018, and there were 121 PCI cases between 2008 and 2016. Almost 40% of cases were those which were balloon uncrossable, 50% of cases were balloon undilatable, and 10% to 15% were thrombus containing lesion. Size of the catheter is important, and when we activate the machine, the settings are energy we use about 80 and fluence about 80 with a 0.9 mm size of the catheter. We use a saline flush, but the important is that when you advance the laser catheter, you do it slowly. So it is 1 millimeter advancement per second. That is very important when you're using the laser catheter, because if you do it slowly, then you get a lumen gain of close to 6 mm. If you do it fast, then you get a lumen gain of 3 mm. So very important slow advancement as compared to a fast advancement. Balloon uncrossable, which does not cross after successful guide wire position. So the guide wire is placed in the distal lumen and the balloon cannot cross, even a 1.5 or a 2 millimeter balloon, in which case laser will be able to modify the lesion. But when you're putting the laser catheter, you definitely need a good guide support. So if this is the right coronary artery, one can use a AL1 catheter and be sure that the guide is very much inside. So if you look at this particular case, this is a CT of the right coronary artery, and this is the LED, and there are septal collaterals which are retrogradely filling the distal right coronary artery. So this is the right lateral view, which shows that the CTO has been crossed with the Gaia 2 wire, and this is the fine cross microcatheter. And even 2 millimeter by 20 millimeter balloon cannot be advanced. Then we tried a 1.5 by 20 millimeter balloon, but again it cannot be advanced. And even with the support of a guideliner and granuloplasty, where repeated balloon inflations were done with smaller balloons, rupturing the balloon, but we just could not create the lumen. And the laser has been used, 0.9 mm laser, 2 runs of frequency of 40 Hertz, of fluency 60, and a very slow movement of the laser catheter, 1 mm per second, and we've been able to create a lumen. And once you've created this lumen in this CTO to the right coronary, then it becomes easy. And here this is after deployment of the stent and the final result. The other indication is a balloon undilatable, which I just, this is the balloon undilatable lesion. So this is a BMW wire and this is a balloon catheter. You see the waist on the balloon catheter. It's a very tight stenosis, went to almost 30 atmospheres, but it would not open up. So this is the algorithm that we use, and laser forms a very important part of this algorithm. And this is a stent under expansion in which a laser can be used. So you see this is the right coronary artery and there is an in-stent restenosis. This is a cyan blue wire. Even to get a cyan blue, we needed a microcatheter support. And after the cyan blue has gone distally with the microcatheter support, this is the balloon. And you see that a 2.5 millimeter NC balloon and a cutting balloon has been used, followed by an angiosculp, but the lesion would not open. And here the laser catheter, you can see the laser catheter go very slow, 1 millimeter per second. This is without contrast, and this is laser with a contrast. But important is that when you use a contrast, be careful of the bubbles going distally. And after the lesion is opened up, the additional regulating stent has been deployed, 2.75 by 8 mm post dilated with a 3 mm balloon. And this was the final result. And this is IVUS done to show that the stent struts are now well opposed on the arterial wall. So the conclusion was that lasers are very good for in-stent restenosis, for also in-stent restenosis with the CTO, also for underexpanded stents, also for uncrossable lesions and undilatable lesions. Only caution with the laser when you are using with contrast, because it may lead to intracoronary bubble formation. So one has to be careful about it. The other indication of laser is thrombus, again a very important indication. So this is the algorithm of how you handle a thrombus. Normally we use a thrombectomy catheter, and sometimes even after using an export catheter, the thrombus is still there, in which case laser. So the last two cases that we did were both PAMI cases to the right coronary artery, where we have used a laser because the patient were elderly patients with very calcified arteries with a huge thrombus burden, in which the laser worked out very well for these patients. So one of this is the patient with a huge large thrombus in the right coronary artery. This is export catheter to suck out the thrombus. But despite using an export catheter and sucking out the thrombus, you find a large filling defect here. And then a laser catheter has been used, followed by balloon dilatation, and then you see the fantastic final result after the laser. So in conclusion, I will tell you that lasers are a very important part of treatment today in the cath lab, and coronary lasers are working very well. Only the machine is bulky, it's like 650 pounds weight. So, and it takes to warm up about 5-10 minutes. So you have to prepare the machine beforehand. You have to prepare the catheter. It's very easy to prepare the laser catheter, very easy to use. It's a 0.9 mm, so little bulky catheter. But once you take a proper guide support and you have a good wire, then it goes. Even if it doesn't go and it just reaches the lesion, and if you give the light energy, it will help to ablate the plaque. So as we know that it's a light energy, sonic wave bubbles are vapor bubbles are created, and that helps to debulk the plaque, to improve the lumen in the catheter. Especially a hard atherosclerotic calcified plaque doesn't cause distal embolization. Perforations are almost unheard of. Dissection is much less, and lasers are really turning out to be a boon in the cath lab, especially for balloon uncrossable, balloon undilatable, thrombus containing lesions, and for in-stent restenosis and for CTO. Thank you for your very patient hearing.